Welcome to Washington Hospital Today, the program dedicated to sharing timely information about the community hospital that's been taking care of Washington Township Healthcare District residents since it opened in 1958. Washington Hospital Today is provided for the sole purpose of informing residents about healthcare topics and issues that have been covered during community forums, free health and wellness classes, or as part of educational sessions held during the district's open board meetings. This program is one more way that Washington Hospital helps empower you, the residents of the district, by providing information needed to make informed decisions about your health.
Today's presenter is Dr. Arun Srivatsa. Dr. Srivatsa completed his undergraduate training at St. Joseph's College in Bangalore, India. He graduated from Bangalore Medical College. He completed his internal medicine residency as well as his gastroenterology fellowship at the University of Rochester Medical Center in Rochester, New York. Dr. Srivatsa is board certified in internal medicine and board eligible in gastroenterology.
If you're experiencing any of the following symptoms, abdominal pain, bloating, constipation, we will be talking more about those situations. We'll also touch briefly about irritable bowel syndrome, celiac disease, diverticulosis, and so forth. So almost everyone has had abdominal pain several times during their lifetime. What I'd like to do today is to describe how a physician would approach trying to diagnose someone with abdominal pain and allow you to understand what we're looking for to try and make you feel better when we try to diagnose your symptoms. So when we're looking for a patient with abdominal pain, we look for where exactly it's located, which will allow us to do certain tests to work up the possible reasons why you might be having pain. And we're going to touch briefly upon the differences between diseases that cause acute pain versus chronic pain. So let's start with epigastric pain. This is pain right in the pit of your stomach, right between the ribs and the upper part of your stomach. Some of the common causes of epigastric pain would be peptic ulcer disease, acid reflux. You could also have more serious conditions such as pancreatic causes of pain in this area. Gallbladder pain can present in this area as well. Sometimes a heart attack or more serious conditions like abdominal aneurysm can also cause pain in this area. On the other hand, pain towards the right side of your upper abdomen, which is called right upper quadrant pain, usually is related to your gallbladder. Pain from gallstones or stones that have passed into your bile duct can cause pain in this area. You could also have pain from liver disease, such as hepatitis or a liver abscess, and that would hurt in this area. Unfortunately, the heart can always cause pain in these upper regions. So if you have congestive heart failure, it might cause pain in this area as opposed to over your heart. Similarly, a peptic ulcer that perforates in the duodenum can cause pain here. Elderly folks with herpes zoster may have pain here before the rash appears. Another common cause would be pneumonia on your right lung, especially the lower part of your right lung that might present with pain here. Going to the opposite side, the left upper side of your stomach area can have pain from pancreatitis or a peptic ulcer in your stomach. It could also be from diseases of the spleen, such as splenic enlargement or trauma to the spleen. Again, a heart attack or pneumonia in the left lower lung can present with pain in this area. What about some causes of lower belly pain? So on the right side of your lower belly is typically where the appendix is. So appendicitis is classically usually presents with pain in this area. Similarly, diseases of the small intestine such as Crohn's disease, also known as regional enteritis, or a small bowel obstruction can have pain in this area. Other rarer causes would be, again, a leaking aneurysm. In younger females, ectopic pregnancy or pelvic inflammatory disease, twisted ovarian cysts can present here. Similarly, a hernia or a kidney stone that has passed into the tubes down the kidney can cause pain here. Moving to the left lower site of abdominal pain, most commonly we see diverticulitis as a condition that causes this symptom. Again, other rare causes would be ruptured ectopic pregnancies, leaking aneurysms, ovarian cysts, kidney stones, hernias, and Crohn's disease. What about pain right around your belly button? This is usually related to small bowel pain that hasn't really progressed to any particular part of the intestine. So a typical viral gastroenteritis or a bowel obstruction could present with pain here. Appendicitis in the early stages. Similarly, colon disease in the early stages can present with pain here. Sometimes pain is diffuse, it's felt all over. That's known as diffuse pain. It could be a sign of a serious underlying issue such as generalized peritonitis, which usually occurs when an organ has actually ruptured, and therefore the entire abdomen is painful at that point because of the inflammation is spread throughout. Similarly, acute pancreatitis can present this way. People with sickle cell disease can have pain all over the abdomen. Disorders of the blood supply, such as clots in your blood vessels, known as mesenteric thrombosis, can present like this. But other milder problems, such as viral gastroenteritis, disorders of blood sugar, or other electrolyte imbalances, generalized intestinal obstruction can also present this way. So sometimes your physician may say the pain is referred. And what that means is the pain actually is present in an organ that is away from the site that is being described as painful. So as you can see in the picture here, liver pain and gallbladder pain can go to your right shoulder, so they're referred to the right shoulder. Similarly, kidney pain can come to the front. Pancreatitis pain or ulcer pain can go to your back. Then again, as we mentioned, pneumonia, especially infection of the lower parts of your lungs, can come down and be referred to your stomach. Same thing with your heart. A heart attack involving the lower part of the heart can be actually felt as abdominal pain. Visceral pain is defined as pain that actually truly arises in an organ within your abdomen. Colicky pain is pain that comes and goes as cramping, intensifies, then reduces in intensity, and then goes away. That could be a sign of a visceral type of pain, but could be seen in a variety of other conditions, which we'll talk about. And then we have parietal pain, which is from irritation of the peritoneum, and referred pain again, which is produced in some other location. And this diagram shows you why pain is so imprecise, because your brain and spinal cord receive impulses from the skin as well as other organs, and they all merge. So for your brain to map out the exact GPS location of that pain is imprecise, and it frequently confuses pain from deeper organs to the skin, which is why you feel the pain is right where you touch, but actually might be deeper or in some other location. Now, these are some of the things that physicians use to distinguish what pain might be serious and what pain might not. So when we call pain organic, that means there's some disturbance that really needs to be fixed, usually right away. Whereas sometimes pain is functional, where the pain is present, but there's no real disturbance that's threatening life or limb at that point. So some things that would help us distinguish would be the character of pain. So acute, persistent pain that continues to increase in intensity, probably organic. Functional pain could be colicky, could come and go. It doesn't intensify. Pain that is sharply localized to one point, especially away from the center of the abdomen, probably organic. But pain that is present in various locations at different times is usually less likely to be serious. Pain that wakens you up at night, usually very serious. Functional pain, usually people are able to sleep through it. It might affect them during the day, but they usually have a good night's sleep. As we said, pain that is usually further away from the umbilicus, the center of your belly button, the more further away it is, the more likely it is a precise cause that needs to be fixed. If pain is centered around the umbilicus at most times, probably not as serious. Other symptoms such as fever, weight loss, lack of appetite, vomiting, abnormal blood tests all indicate more serious causes that need to be further investigated. On the other hand, if the patient has headache, dizziness, multiple complaints outside the abdominal area, less likely to be a true organic cause of abdominal pain. Doesn't mean the pain is not real, it just means that there probably is no visceral organ that's causing that pain. Psychological stress can cause a lot of functional pain. Everyone has had butterflies in their stomach before they give a speech, like what I'm doing. But when someone says, "I'm not stressed, doc, I'm really having pain," the stress is actually because of the pain, not the other way around. Now, that tells you that there actually is something going on there. When you see your physician or your healthcare provider, they're going to ask you these questions. They're going to ask you, when did the pain start? Can you describe the pain? Can you describe its intensity? How often does it come on? Does it go anywhere else? In other words, is it referred? How long have you had it? And what makes it better or worse? So just bear with them while they ask you that, because they're trying to figure out what it is that's causing your pain. Most people would follow this set of physical examination steps when they examine you. They'd inspect your abdomen, then they'd listen to it, usually with their stethoscope. They might tap on it, that's called percussion. They might try and feel which organ is inflamed. They might look for what's known as guarding or rebound tenderness. Those are two different signs that occur when usually an organ might have ruptured or is very acutely inflamed. And if appropriate, they may do a rectal exam or a pelvic exam. Typically, the step following that would be to do some lab tests, including your urine and blood. Depending on where exactly your pain is located, they might order some special tests to look for your pancreas and liver and kidneys to see if those are inflamed or if those are abnormal. More severe abdominal pain usually needs imaging. It could be as simple as a plain X-ray, which has been there for several decades. You might need a barium study, an ultrasound, a CT scan. Those are all different types of imaging techniques. More advanced techniques are MRIs. Sometimes we do order an endoscopy or a sigmoidoscopy or a colonoscopy, depending on the type of pain you're having. So let's move on to some common acute pain syndromes. These cause severe pain that comes on suddenly. So this is a list of what we will try to cover, starting with appendicitis, diverticulitis, and so on. So let's tackle this one by one. Appendicitis, a really common condition. Probably the most common surgery performed in the United States is an appendectomy. Basically what it is an inflammation of the wall of the appendix. And the appendix is a tiny little part of your intestine that's located on the right side, lower down, right by your large intestine. So a surgeon would say there's a classic sequence of symptoms that starts with usually pain in the center of your abdomen that slowly migrates to the right side, followed by vomiting and maybe some fever. But the pain is pretty intense, doesn't go away. This is a diagram trying to show how that pain radiates. It starts right around the umbilicus and within 3 to 6 hours starts moving down to the right side. That spot there is known as McBurney's point, and when the physician pushes on that, it's very painful. So if that's the case, one should rule out appendicitis. Tests would show that your white blood count is usually high, especially within 12 hours of the pain starting, because it is an acute inflammation and could be an infection as well. You could do a CT scan, which some surgeons might say we don't even need that. They'd straight away take you to surgery and get your appendix out if they're pretty confident that that's what this is. But usually a CT scan would show inflammation and infection of the appendix. The treatment is usually surgery, but in late cases, if surgery is not possible or the surgeon's not available, you could treat this with IV antibiotics. Moving on to diverticulitis. So this diagram tries to show you, again, the large intestine, which is the organ that's affected usually by diverticulitis. And you see these little pockets, especially on the left side, the left lower side of your colon, that can get affected by this condition. Usually it's from stagnation of fecal material, usually in a single pouch known as a diverticulum. And what this does is it causes progressive infection, inflammation, may cause some bleeding, may cause an abscess, and even perforation. So the symptoms could be mild, could be moderate, could be severe. Usually it's pain on the left lower side. Starts off pretty steady and aching, keeps getting worse, is worse when people push on it. Could progress to fever and constipation. You're not able to pass gas as the swelling starts involving the whole large intestine. So again, here's a picture of an outpouch known as a diverticulum and a little inspissated piece of fecal material or vegetable matter that can cause that condition. Usually this is a clinical diagnosis, meaning you don't typically need a CT scan or blood tests, but most people would order that just to be sure. You could see an elevated white count known as leukocytosis. You could do a CT scan that would show inflammation of that pocket in your large intestine. This is a colonoscopic view. This is the way diverticulosis looks on the inside with these pockets. And here's an example of an impacted diverticulum, which can progress to diverticulitis. Sometimes these can resolve spontaneously as that piece of material is passed, but usually it does need antibiotics. So we tell people to limit their physical activity, drink plenty of fluids, reduce the solid intake. We'd start with oral antibiotics, but if they don't work, severe cases may need admission and IV antibiotics. Cholecystitis is the next condition we'll talk about. This is inflammation of your gallbladder. A normal gallbladder looks nice and green and is healthy with no stones within. Gallstones can pack up your gallbladder, and chronic movement of these stones within your gallbladder can inflame it, leading to edema and infection. So usually cholecystitis is inflammation of your gallbladder resulting from obstruction by a large gallstone. That's the most common cause. The stones could also pass the gallbladder into the bile duct and cause blockage of your bile ducts as well. Typically, pain is on the right side in the upper part of your right belly. Usually, again, tender to touch. People don't want to be examined there. It hurts when you take a deep breath. Sometimes it gets referred to your right shoulder because the same nerves supply your shoulder and the gallbladder. So here's a picture of stones within your gallbladder, and they can pass and block either the gallbladder or the bile duct from the liver, in which case your liver numbers do go up. So that's what we would test for. We check for evidence of high liver numbers, high white count. Sometimes it can inflame your pancreas by blocking your pancreatic duct. An ultrasound can usually show these stones. There's a specific scan known as a HIDA scan that tests the gallbladder, which is usually positive in a patient with cholecystitis. Cholecystitis usually needs admission with IV antibiotics, followed by surgery as soon as the patient is stable. Moving on to pancreatitis. The two most common causes of pancreatitis in the United States are alcohol and gallstones. And the pain usually is pretty severe, steady and boring, and it goes right from the center of your belly, right all the way back to almost your spinal cord. It feels like someone's stabbing you through and through. So it's a pretty severe pain. Nothing relieves the pain. Sometimes there's nausea and vomiting. Patient is really sweaty and pale, usually pretty ill, and usually needs admission. Mild cases of pancreatitis may go unnoticed, but more moderate and severe cases usually need admission. Here's a picture of gallstones blocking the pancreatic duct, causing inflammation of the pancreas. So this is a very common condition, needs admission and needs those stones removed by a technique known as ERCP, where we extract that surgically. So again, common tests would show your pancreas numbers being high. An ultrasound or a CT scan may show evidence of inflammation of the pancreas, may show the stones. The treatment usually is admission with IV fluids and pain control. Moving on to the next condition, peptic ulcer perforation. Again, this is another severe situation that can cause bad abdominal pain. It's a life-threatening complication of peptic ulcer disease. The duodenum is more commonly perforated than the stomach because it's thinner than the stomach. Predisposing factors include certain bacteria known as Helicobacter pylori, any non-steroidal anti-inflammatory or painkiller such as Advil, ibuprofen, naproxen. Here's a picture of the stomach with an ulcer that can actually create a hole literally within your stomach and bleed out. So again, this pain is pretty intense, keeps getting worse, can radiate to both shoulders or your back because the nerves that innervate the stomach radiate to both shoulders. There is a history of previous acid reflux that was probably not well controlled. Physical findings would show severe pain right over the stomach area, and the patient usually has the guarding or rigidity because they're trying to protect themselves from the examining hand. Usually an X-ray or a CT scan would show the site of the perforation, and this is a surgical emergency, usually needs admission and surgery within a few hours. Small bowel obstruction usually occurs, as in this diagram, there's one point in the small bowel that decides to get blocked for whatever reason, and everything upstream from that starts getting distended with the digestive juice and with the food that the patient has been ingesting. So vomiting occurs earlier with the point of obstruction being higher up. So the more lower down your obstruction is, the more late vomiting is going to occur in relation to the pain. Certain things that might cause a bowel obstruction could be hernias, could be adhesions from prior surgeries, could be a condition known as intussusception, where part of the intestine squeezes into the next part, or what's known as a volvulus, where the intestine actually rotates and squeezes itself that way. Diagnosis is usually made based on a CT scan or X-ray, and usually needs hospital stay, surgery to relieve the obstruction. And one more, acute abdominal syndrome, which is technically not an intestinal organ, but is actually related to the cardiovascular system. So this is a rupture of your abdominal aorta. And this usually occurs in more elderly folks with a history of smoking, can be fatal even before they hit the hospital, because this is the biggest blood vessel in the body, and when it does rupture, you tend to go into shock almost immediately. So it's again a sudden, excruciating pain that's usually felt right in the midline, radiates to your back. And the patient usually is in shock, usually doesn't have pulses that can be felt, especially lower down. A CT scan would usually diagnose this. And again, this is a vascular surgical emergency. So I just wanted to touch briefly about pelvic pain, because this, although technically is not an abdominal issue, does need to be kept in mind, especially in females. So ectopic pregnancy, ovarian cysts, pelvic inflammatory disease, and even UTIs can all cause pelvic pain in females. And they may present to the internist or the gastroenterologist, while they may actually need a gynecologist to take care of the specific situation. We're going to now move on to the chronic pain syndromes, which means the pain has been present for several weeks, maybe even months or years, hasn't been that severe that you needed admission, but still can be significantly impacting your life, your work, sleep, and basically your quality of life. So irritable bowel syndrome, it's kind of an enigma still to most patients and to most physicians, because no one really knows what causes it. It's a condition classified as functional, which means by definition there should not be anything structurally wrong with the intestines or the stomach or the digestive system. By definition, there's nothing structurally wrong. By definition, there are no biochemical abnormalities, which means your labs usually are completely normal. But it affects 14 to 24% of females and 5 to 19% of males. So that's a pretty heavy statistic. The usual onset is in late adolescence to early adulthood. So most people don't get this for the first time after 50. So if someone has never had IBS, is now over 50 and suddenly starts getting these symptoms, one should be careful about calling this IBS, because usually IBS starts late teenage to early adulthood. And this diagram tries to show your large intestine, which looks pretty healthy, but then is undergoing spasmodic contractions. So it's just like a muscle trying to flex in a painful way, cramping, but there's nothing intrinsically wrong with it. It's just irritable. And we think the pain comes from the muscular spasms around your large intestine. We're still trying to figure out what causes it. So this is a schematic cartoon about the various other symptoms that can coexist with irritable bowel syndrome. So it's not an isolated disorder. Usually the patients have associated headache. They may complain of dry mouth, which is the Sika syndrome. They may have a feeling of a lump in their throat, especially during times of stress, swallowing difficulties, but testing shows that there's nothing wrong with those organs. They could have episodic chest pain, nausea, heartburn. There's usually a lot of bloating and abdominal distension. There could be urinary symptoms in the absence of any abnormal urinary findings or absence of UTIs. There could be other associated symptoms such as chronic fatigue, fibromyalgia, back pain, and pelvic pain. So in terms of the actual abdominal pain, it's described as non-radiating, meaning it usually stays in one spot, usually is crampy, intermittent, and usually lower down, usually at the umbilicus, the belly button, or below. Things that exacerbate this usually are meals, stress, and right before having a bowel movement. And what relieves this usually is having a bowel movement. Usually most people are relieved once they evacuate their bowels. By definition, IBS does not interrupt sleep. Although people may have some insomnia, they usually don't wake up because of the pain. So certain things are shown in this picture. We don't know if psychosocial factors play a role. We don't know if people suffered an infection in the remote past that just made their intestine more sensitive. We don't know if they have visceral hypersensitivity, which means that their organs are just more sensitive to pain than the next person. Things such as altered bowel motility and imbalance of neurotransmitters have also been described, but nothing has been conclusively proven as the single etiological factor. In terms of a diagnosis, we need at least 3 months of symptoms in a recurrent or continuous pattern. Usually there is pain, which is relieved by having a bowel movement. Usually the stools are different. People say they're having more frequent or less frequent stools. Usually they say their stools have become either lumpier, harder, or they've become more loose. So usually we need that change in frequency and change in consistency of stool as well. So certain other criteria are usually we need symptoms on 25% of all days where they report these symptoms. And we need either more than 3 bowel movements a day to qualify it as loose stools, or less than 3 bowel movements a week to qualify it as the constipation side of IBS. And there also are certain symptoms such as straining during a bowel movement, having an urgent symptom of needing to evacuate, or a feeling of incomplete evacuation in terms of having a bowel movement. Some people also describe passing a lot of mucus or feeling bloated and distended all the time. So the diagnostic tests for irritable bowel syndrome are mainly centered on ruling out organic causes of pain, meaning you rule out underlying pathology, and if everything comes out normal, you could say the patient has IBS. So we'd start with a blood count, looking for evidence of infection, a celiac panel to make sure they don't have celiac disease, checking their electrolytes, liver numbers, thyroid numbers, checking the stool for infection and for bleeding. They might need a colonoscopy or endoscopy to be certain that everything looks normal even on the inside. They might need a CT scan or an ultrasound to make sure there's no other pathology involved. So what would be the goals of management? Well, the primary goal of management is to make them feel better. And that includes providing support and reassurance. So most people are reassured if all their tests come out normal, but they may still find it frustrating that nothing can be done or nothing has been found to explain their symptoms. The next steps would be dietary modification, certain medicines, also known as pharmacotherapy, and certain alternative therapies, which we're going to describe in just a second. So before we go ahead, one has to note that GI consultation is indicated if this initial treatment of IBS fails, or if organic disease is suspected but cannot be proven yet. And again, if a patient is over the age of 50 when presenting with new symptoms of IBS. So what would be certain things you could use to treat the condition? So apart from reassurance and education about good bowel habits, a diet known as a FODMAPs diet has been becoming more popular. We're going to talk about FODMAPs in a second. But basically this diet reduces gas formation, reduces lactose and gluten exposure. The next step would be physical activity. So people who are not active, they find that most of their symptoms actually improve with recommended levels of exercise and physical activity. Certain fiber supplements also help most people. There are medicines for diarrhea. Apart from over-the-counter antidiarrheal medicines, you could use, in severe cases, Lotronex or Viberzi, which we'll talk about in detail. For constipation, apart from over-the-counter constipation aids, one could use these stronger medicines called Amitiza and Linzess. So a FODMAPs diet is an acronym for fermentable oligosaccharides, disaccharides, monosaccharides, and polyols. So that's a mouthful, but that's why they termed it as FODMAPs. So basically what these are sugars found in plant and vegetable and fruit matter. These are sugars that are found but are not digested by the human body, but they're digested by the bacteria found in your intestines. So basically, it's food for your bacteria. And almost every plant or vegetable or fruit has some FODMAPs, and some of them produce more gas when the bacteria in your intestine digest these. Some of them produce less. And based on that statistic, they've classified foods into high FODMAPs, which produce a lot of gas, bloating, can cause cramping, diarrhea, because of the level of bacterial decomposition of those sugars that you're not digesting. And so this is a small list of those substances. And as you can see, gluten and lactose figure in that list. And certain things that you know, like onions and beans and lentils and nuts, everyone knows through experience that those do tend to produce more bloating and gas and discomfort. But the FODMAPs is widely available on the internet. There's different universities and different nutritional centers that have created their own list of FODMAPs. And there's more research going on into teasing out which of these substances causes more bloating than the next one. So you can have low FODMAPs, which would be foods to selectively partake, and high FODMAPs, which would be the foods to avoid, to reduce gas and bloating. So moving to medicines for irritable bowel syndrome, there are some medicines that are relatively low risk, low incidence of side effects. These would be the first line of treatment. Amongst them are dicyclomine, also known as Bentyl, and hyoscyamine. Then there are the gastrointestinal neuromodulators, such as amitriptyline and nortriptyline. What these medicines do is they just reduce the intensity of signals coming from your nerves, from your visceral organs. So if your colon is going into spasm but is otherwise healthy, the intensity of that spasm transmitted to your brain is reduced by these medicines. So they're not really fixing anything, they're just reducing the volume of traffic your brain is getting from the intestines. Certain antibiotics such as rifaximin have been used in people who have had a bout of food poisoning. They recover from food poisoning, but they continue to have these episodes of IBS, which is known as post-infectious IBS. Probiotics. I'm sure a lot of you have heard or maybe even tried probiotics. There's a bunch of probiotics out there, including lactobacillus, VSL3, and Saccharomyces. Unfortunately, there's no proven role of probiotics in irritable bowel syndrome. So we cannot recommend probiotics for anyone with IBS. But if people have tried certain probiotics and they feel better, they could continue using them, although there's no proven benefit for that. VSL3 is a lactogenic bacteria, including a bunch of bifidobacteria and lactobacilli and a streptococcus. And this group has been clubbed in one capsule or packet known as VSL3. And then you have various other probiotics such as Align, Cultural, Floraster, Mutaflor. There are various ones on the market. To be used with caution and certainly not proven benefit. So let's move on to celiac disease, which is another pretty common condition, estimated to affect 1 in 100 people worldwide. This is a more serious disorder where there's actually a genetic predisposition for your body to attack gluten. And the gluten is basically a substance found in wheat. And when that coats the insides of your intestine, your body launches an immune reaction against the insides of your intestine, which is not good for the body. So about 2.5 million Americans are estimated to be at risk for celiac disease. So what is gluten? It's a protein. It's a protein found in wheat predominantly, but also found in other cereals such as rye, barley, and even oats. And when people eat gluten and they have celiac disease, the damage is basically centered on the villi. The villi are finger-like projections that line the small intestine. And this is what happens when a person with normal villi but has celiac disease ingests gluten, and the gluten coats those absorptive surfaces, and the body launches an immune reaction to that, and your villi get damaged, and so you no longer can absorb as much as you used to absorb of anything, almost everything. So you can understand how it causes malabsorption and diarrhea. So this is from the celiac disease website. This is called the many faces of celiac disease. Because the villi are damaged, you could essentially have any of these symptoms, or you could have virtually no symptoms but still have very bad celiac disease. Osteoporosis, weight loss, bloating, constipation, fatigue, anemia. You could be misdiagnosed as irritable bowel syndrome, especially with mild celiac disease. You could have various vitamin deficiencies, and so on and so forth. The most common signs and symptoms would be iron deficiency anemia, especially in males, early onset osteoporosis or osteopenia. You could have vitamin and mineral deficiencies. In severe cases, your nervous system and your brain start getting affected, especially if vitamin B12 and folic acid and vitamin B6 are low. They can cause neuropathy, myopathy, in severe cases even seizures. Pancreatic issues can also occur because of involvement of the pancreatic duct itself, causing pancreatic insufficiency and gallbladder dysfunction. Other rare, more severe consequences of celiac disease are infertility, recurrent stillbirths, short stature with delayed puberty in children, higher incidence of migraines, abnormal liver numbers. Certain people are at higher risk, such as people with type 1 diabetes, people with Down syndrome, and siblings of other people with celiac disease. This is a diagram of the more rare consequences, including dental disease, muscle disease, and as we mentioned about recurrent miscarriages and infertility in females. Even more rare would be certain cancers, because chronic inflammation over several decades with the immune system just chronically attacking your intestines could damage it to the point of causing cancer. So certain small intestinal cancers, esophageal cancers, and lymphomas can be seen with celiac disease. So the test for celiac disease is a simple blood test. Can be easily done. You don't even need to fast. Usually get results pretty fast with a turnaround less than a week. We encourage you to be on a gluten-containing diet before getting tested for celiac, because what we're actually measuring is antibodies to gluten in your blood. So if you're on a gluten-free diet, you may have celiac but have no antibodies in blood, so it's important to be aware of that when you get tested. Usually, your physician may recommend a biopsy of your small intestine to look at those villi, because that is the diagnostic test for celiac disease. You could also have a genetic test for certain genes, such as the DQ2 and the DQ8 genes, which are associated with celiac disease. So currently, the best and only treatment for most people with celiac is a gluten-free diet. And this needs to be pretty strict if you really have celiac disease. You must entirely avoid any food containing wheat, even rye, barley, and that includes things such as beer and things prepared on wheat-containing surfaces. So some restaurants will say this is gluten-free, but they may have prepared that food on the same surfaces that they prepared other food, and that might be all that's needed to tip someone with celiac back into a flare. As we said, ingesting even small amounts of gluten, such as crumbs from a cutting board or a toaster, can trigger symptoms. Apart from avoiding gluten, your physician will also recommend periodic testing for bone density, monitoring your antibody levels, screening your family members, and also prescribing certain vitamin and bone health supplements. So we're going to move on to constipation now. This is probably the most common digestive complaint that we see, apart from heartburn, for example. So simply put, constipation is a lumpy or hard to pass stool, but can also be defined as less than 3 bowel movements a week, along with a sense of incomplete evacuation and straining. So this is a laundry list of some causes of constipation, usually need to be excluded before someone terms it slow transit. Most people with constipation just have a slow transit time. That means your colon just takes longer to evacuate. But certain neurological disorders, such as multiple sclerosis, Parkinson's disease, diabetic neuropathy, Hirschsprung's disease, all affect the nerves supplying your intestine and therefore must be looked for in people with constipation. Certain people with IBS have constipation. Certain medications may cause it. We'll describe those in the next slide. Hypothyroidism is an endocrine disorder that can cause constipation. And there are a bunch of other endocrine issues, including the hormonal changes in pregnancy that affect your intestinal transit. But most people fit into what's known as idiopathic constipation, with a slow transit being the most common type. Now, it's always worth, especially in older folks who are taking a lot of medications, to look for certain medicines that might be worsening constipation. And these include antihistaminics such as Benadryl, antispasmodics, narcotics and opiates, certain anti-blood pressure medicines such as calcium channel blockers, iron supplements, certain antacids, certain antidepressants. Now, when would constipation actually be a dangerous symptom? These would be the signs of someone with an underlying malignancy: bleeding, anemia, stool occult blood being positive, weight loss, and a family history of colon cancer. So if you have any of those and your constipation is either there or getting worse or is a new symptom, we recommend you get a colonoscopy. The first step in treating constipation would be a fiber supplement. These are pretty widely available over the counter. Those are some examples of products that are available over the counter. In addition, a high fiber diet is usually prescribed, and the Washington Hospital Nutritional Service has an excellent high fiber diet supplement and natural foods that contain high fiber in them. So there's easily available links on the internet for you to download as to what constitutes a high fiber diet. The next step would be to use a stool softener such as Docusate or Colace over the counter. And in the more severe cases, people do need a laxative. Some common laxatives are Miralax and lactulose, as well as milk of magnesia. Some of them can damage your kidneys, so you need some caution in using them if you're using them by yourself. And then in the more severe cases, we could prescribe Linzess and Amitiza, which are two prescription products specifically designed for constipation. And they increase both chloride secretion and, in some cases, bicarbonate secretion to actually improve your stool consistency and output. So let's move on to acid reflux disease. As the term acid reflux indicates, it's a movement of acid or gastric juice from the stomach back up into your food pipe, and may cause symptoms not only in your stomach and food pipe, but may also go as high up as your pharynx and larynx, may even cause problems in your lungs and in your breathing. This is a pretty common symptom. About 15% of adults are reported to use antacids, sometimes as commonly as once or twice a week. Heartburn is the most common symptom and can be pretty severe even though the tissue may actually be normal. It's a sensation of burning right behind what you think is your heart, but is actually the food pipe. Sometimes there's a burning and more of a chronic sensation in the pit of your stomach, which is the epigastric area. Usually symptoms get worse with lying down. You could taste food or salty acid or bitter tasting acid coming back up into your throat. This picture shows you the stomach lining here, and usually there's a sphincter here, which is a tight muscle that closes down the valve that prevents acid from leaking back up. And as people grow older, certain medicines and alcohol play a role in weakening this, acid then starts coming back up. So some people actually have trouble swallowing, which is dysphagia, and painful swallowing, which is odynophagia, and that usually indicates more severe disease that might need an endoscopy to evaluate. You could have chest pain that might make you think you're having a heart issue, and usually certain foods that are high in fat or chocolate or coffee and citrusy, tomato-based or spicy foods that aggravate this condition. Things that actually worsen the damage related to acid are smoking, alcohol, and aspirin-like medicines. So again, in terms of diagnosis, in severe cases, one would rule out underlying ulcers and other pathology by doing an endoscopy. One could try certain medicines to see if they help. One could check for bacteria such as H. pylori. So this is a schematic on how to treat acid reflux. Basically avoiding all the fun stuff is what I say. So you eat smaller meals, you avoid alcohol, you avoid smoking, you reduce weight, you maintain a more healthy lifestyle by walking around after you eat, reducing weight, and avoiding tight clothing. These are some foods that you want to avoid, especially chocolates, tomato-based and citrus-based foods. You also want to avoid Advil and ibuprofen and aspirin-like medicines. So these are some of the medicines that you can use to actually treat acid reflux. Most of them are over-the-counter. Antacids such as Pepcid or Maalox, Mylanta, all these are freely available over-the-counter. Certain H2 receptor antagonists are stronger, and that would be, for example, Zantac. Most people would heal with just an H2 receptor blocker, but for people with more severe disease, we use a proton pump inhibitor, and these are some of the medicines that are available. Some of them are, again, over-the-counter, such as Prilosec, and usually can be dosed once a day, and usually are pretty effective and can heal even ulcers within 4 to 8 weeks. We're going to move on to another topic, which is diverticulosis. This is a different condition than what we talked about before, diverticulitis. This condition is the uncomplicated presence of these pouches. When these pouches are present in your large intestine, but are not infected, they're not inflamed, that condition is known as diverticulosis. And it's a pretty common condition. The incidence is usually about 20 to 30% in your 30s, goes to about 40% in your 40s, and 50% in your 50s. And usually the older you get, the more likely you are to have this condition. So we believe it's a disease of the Western civilization, meaning a fat-rich and fiber-poor diet, and it can occur in all ethnicities, usually produces no symptoms. 80 to 85% are just found incidentally during a colonoscopy or during a CT scan. But some people, because of vegetable matter or stool getting stuck in these pouches, can complain of intermittent bloating and gas and irregular bowel habits. And it's a function of having not enough fiber in your colon. So as your colon tries to contract, it's literally creating these pouches of weakness because of its extra work it's creating to squeeze through. So because of that extra pressure, some people report a flat or ribbon-like stool. Some people complain of steady or crampy pain. It may mimic irritable bowel syndrome, but usually is present in an older age group. So we would basically do a CT scan or a colonoscopy to confirm this. And here you can see some of these black pouches in the intestine. One would also do a blood count and check your stool for blood to see if one of these pouches is bleeding, because that would be another presentation. If a hard piece of, like for example, a nut or something sharp that you've ingested gets stuck in one of these pouches, it could cause bleeding, which is usually painless, and that is another presentation of diverticulosis. So the management is usually to increase your fiber, and again, the increased fiber intake, the recommended dose is about 35 grams. We recommend increasing gradually up to that level, especially in people who don't get that much on a routine basis. Physicians would ask you to avoid sharp items in your food, such as popcorns and nuts and seeds. We're not sure if that really helps, but most people do have good symptom relief when they start avoiding these substances. So the question was, even if they're chewed properly, the small spicules can get stuck in these tiny pockets. And the pockets are not very much bigger than half the size of a thumbnail. So we're going to touch briefly about peptic ulcer disease now. We see an increasing incidence of peptic ulcer disease, mainly because of increased use of non-steroidals such as aspirin, and also because of a bacteria known as Helicobacter pylori. So to produce an ulcer, we need two things to happen. One is we need an increase in acid production and or a decrease in the ability of the stomach lining to protect itself. And usually both are required for an ulcer to form. And all these factors increase acid production and reduce the ability of the stomach to heal or protect itself against acid. So stress, smoking, and alcohol are the main things that increase your acid production and reduce your healing ability. The other thing would be the pain pills that we talked about related to aspirin. Now this is the a schematic of a bacteria known as Helicobacter trying to enter your stomach lining and how it produces damage of the lining and reduces the mucus, causing an ulcer. More than 90% of all ulcers are caused either by this bacteria or by the use of aspirin-like products. So usually the peak incidence is the 5th to 6th decade. Some ulcers can be cancerous, especially in the stomach. So usually pain is epigastric, and like we mentioned, it's severe and it can radiate to your back, and usually wakes you up at night. And usually there's a history of acid reflux that used to be relieved by taking antacids, but now is worse. Typically one would need to do an endoscopy where we find the ulcer. And for example, in this picture, you're seeing a duodenal ulcer located in the first part of your small intestine. During an endoscopy, we can biopsy for the bacteria to see if you have a bacteria in there. We can also, during an endoscopy, if there's bleeding, try and clip the bleeding blood vessel in an ulcer. But apart from that, the treatment for most ulcers is again a proton pump inhibitor, which completely reduces acid production for up to about 4 to 8 weeks, which is the time needed for the ulcer to heal. And we would also treat a bacteria if it were to be present. And one should not forget to stop the offending medication, which is usually the aspirin or the ibuprofen-related medicine that's causing the ulcer. The last talk for today is inflammatory bowel disease, and we'll talk briefly about this condition, which is another serious but chronic condition that can affect your intestines. The problem with IBD, or inflammatory bowel disease, is there are several periods of remission interspersed with periods of exacerbation. So what that means in plain language is patients can feel really well for long periods of time in between flares, and that makes it more challenging to treat. Just like diabetes or high blood pressure, where there may not be any symptoms and you feel well, and you don't want to take your medicine. So there are two main types, ulcerative colitis and Crohn's disease. So here's a schematic of a healthy intestine versus one with Crohn's disease, which is more thick with muscular hypertrophy and fat wrapping and small fissures and small ulcers within. This is a schematic of ulcerative colitis, which shows you the layers of the intestine are normal, but it's only the lining that gets severely ulcerated. So it's only the internal lining that's actually ulcerated, as opposed to Crohn's disease, which involves all the layers of the plumbing. So here's a colonoscopic view of a normal intestine on your left side, and ulcerative colitis, which is more red, inflamed, and swollen with small ulcers on the right side. So this is a chronic inflammation of the inner lining of your large intestine, usually is present in a continuous fashion starting from the rectum going up. Crohn's disease, on the other hand, involves all layers. And here's a schematic of your normal small bowel entering your large intestine and a normal appendix. Whereas in Crohn's disease, you just get a thickened, inflamed, narrowed loop of small bowel. Crohn's can involve any portion of the digestive system. So 30 to 40% of the time it involves the small intestine, and the rest of the time it can involve both the small and large or just the large intestine. The inflammation is more patchy in Crohn's. So it occurs in different skip areas. So ulcerative colitis is a little more common in men, Crohn's disease a little more common in women, but they're otherwise pretty similar in age of onset, which is usually between ages of 15 to 25, and they occur throughout the world. Again, this is a diagram showing you how ulcerative colitis starts in the rectum and goes straight up and can involve the whole large intestine. Crohn's disease can be patchy and involve several areas of both small and large. So the symptoms of both are pretty similar. You can have diarrhea with pain, bleeding. In addition, you may have extra intestinal manifestations, which might be a skin rash, involvement of the eyes or the liver or your joints. So other complaints might be fatigue and weight loss. Sometimes there's fever and chills in severe cases. So in terms of a diagnosis, most people would start off with routine blood tests, stool tests to rule out infections, and eventually would need a colonoscopy or an endoscopy to take biopsies and prove that this is inflammatory bowel disease. So the management of this is usually specialized, involves a gastroenterologist. There's a step-up approach where we start with level 1 medicines and progress up to more powerful medicines with more side effects. And there's a step-down approach where we start with the most powerful medicines and gradually step down as the disease becomes more well controlled.
We're going to conclude the program, so thank you very much.